Good afternoon. Yeah. Hi. Good afternoon, all. I'm Dr. Narendra, consultant endocrinologist at Apollo Sugar Clinic, Sheshadipuram, Bangalore. All right. Sorry for the glitch. Yeah. So today, as we understand, I'm going to talk about diabetes and its complications, as the topic says. So we all know diabetes is such a prevalent disease in India, and also India is the home for the second largest population with people with diabetes. So there are both the type 1 and type 2 kind of diabetes and other forms of diabetes, which I'm going to discuss in a bit. So to start with, we will just start with the introduction. So what is diabetes? So diabetes is a metabolic disease which causes hyperglycemia. It can be due to decreased insulin secretion or increased insulin resistance, and also increased hepatic glucose output. So these are some of the basic causes for diabetes. And of course, now recently there's a dirty dozen causes of diabetes, which means to say, as the name suggests, there are about 12 reasons for someone to have diabetes. So it can be even at the level of the, apart from the reasons which I just mentioned, it can be at the level of the gut due to some hormones called as the incretin hormone secretion defects, and also the degradation of the incretin hormones. It can be at the level of the kidneys, where there can be increased glucose reabsorption from the kidneys causing hyperglycemia. It can be at the level of the skeletal muscle causing increased insulin resistance, and also at the level of the fat muscle, and so fat tissue, where there can be kind of increased lipolysis, and of course causing hyperglycemia. The other causes recently which were added to this list, which is a decreased testosterone levels in men, is known to cause or increase visceral obesity, and also leading to increased insulin resistance and diabetes. And of course, there's also central cause which has been identified. It's due to the hormone, which is the dopamine. So there's also hyperadrenergic state or increased dopaminergic state in some people, which can lead to diabetes. And also vitamin D deficiency has recently been added. As you know, vitamin D deficiency um, has been kind of related to so many causes other than diabetes. So of course, diabetes is one of the one of the things which can happen because of low vitamin D, which is very important, particularly in infants or children, where vitamin D deficiency is known, or it can lead to type 1 diabetes. So these are the different causes for diabetes. So there are multiple, so diabetes is a multifactorial cause. It's just not one factor which causes diabetes. There are multifactorial reasons which can happen and which can lead to diabetes. So, apart from this, so diabetes is like a kind of chronic illness. Because of this, it's just not a one-time diagnosis and treatment and cure. So it's a chronic illness, and it's an ongoing process. So you need a kind of a multifactorial care or a multidisciplinary care. The idea is just not to reduce the glycemia. So you also have to have reduction in the other risk factor reduction should also be addressed. So you need a multifactorial risk reduction strategy in handling or treating diabetes. So it's just not the glycemia you're treating at. So you're also looking at reducing the cardiac risk, reducing the renal risk, and reducing the stroke risk, or even reducing the retinopathy risk. So there are multi-factor, because diabetes, as we understand, can affect most of the organs in the body. So it's a multidisciplinary treatment or a combined effort to reduce all these factors other than reducing the glycemia and keeping it in control. So now let us look at the numbers. So if you look at diabetes in India, nearly 1 in 18% that is known to have diabetes. That is persons who are diagnosed. So that actual number amounts to about 77 million population with the diagnosis of diabetes. So as I told you, India is the second largest after China. India stands second for the prevalence of diabetes. So it's nearly 77 million population have been diagnosed with diabetes, and out of which it's surprising that again, still about nearly 50 to 57% of them are underdiagnosed. So they're not even diagnosed. So you can understand nearly half of them are still underdiagnosed out of the 77 million population, which is the average estimate as per the recent statistics. So most of them are underdiagnosed, and some of them are in the pre-diabetic range, which I'll talk about in a bit. So even those people are not really screened or picked up. So these are some of the important numbers which we are looking at diabetes in India. So why it is important? Because of these high prevalence of diabetes, it amounts to one of the leading causes of both morbidity and mortality. Nearly about diabetes is known to cause nearly about 2,800 deaths every day, which is related to just diabetes, and of course because of its increased cardiovascular risk factors. So it nearly amounts to a large numbers, increasing the mortality. And so that's about the prevalence of diabetes. Now, if you look at the uh, actual percentage of patients who are actually in control, because obviously diabetes, all these complications or the risk factor increases if there isn't a good glycemic control. That's quite obvious. So you need to have a good glycemic control, and which is whether recommended by the ADA or the EASD bodies, or even the RSSDI and the ESI bodies, which recommend the target blood sugars to be under good glycemic control, which again I will talk about it. So if you look at the good glycemic control population, which is about less than 7% of the HbA1c, when we call the percentage of population staying or the achieving a good glycemic control of below 7% is just about 20 to 25%. So it's a very small number when you actually look at the patients who are uncontrolled, which above the HbA1c of 7%. So nearly 75 to 80% of the population are uncontrolled or have hypoglycemia, and they're above the target of HbA1c of 7%. So it's that scary that most of the patients, nearly 75 to 80% of the population, are kind of beyond the target of 7%, and only about 20-25% are within the target for to say that they are in a good glycemic control. So a vast majority of the patients are still undertreated or kind of underdiagnosed, and because of which it can be both physician-related factors or even the patient-related factors, which can lead to this increased numbers and uncontrolled diabetes. Now, let's move on to the types of diabetes. So there are different types of diabetes. So we'll begin with the type 1 diabetes. So type 1 diabetes is usually amounts to about 5 to 10% of the total diabetes population. It usually occurs in children and young adults less than 25 to 30 years of age. And the most common cause of type 1 diabetes is autoimmune process. So there is autoantibodies which can kind of destruct or destroy the pancreatic beta cells completely, and which can lead to complete insulin deficiency, and because of which obviously there's increased glycemia and diabetes. So that's the type 1 diabetes. Now let's look at the type 2 diabetes, which is the most common or the most prevalent form of diabetes, which happens to be about 90 to 95% of the population with diabetes are usually patients with type 2 diabetes. So the type 2 diabetes usually, again, it's a multifactorial risk factor disease, as I already mentioned. So there are a number of causes like decreased insulin secretion, increased insulin resistance, increase in the liver glucose output, and of course there are other factors which can lead to type 2 diabetes, and they amount to the large population of diabetes population, nearly about 90 to 95% of the patients. And then we have the gestational diabetes, that is diabetes which happens in pregnancy. So this also is a very common clinical scenario when we see pregnant women coming with diabetes diagnosed in their pregnancy. So it's also important to be kind of identify the patients who are actually gestational diabetes patients, and who are actually patients who are pre-gestational diabetes and are diagnosed at the time of their pregnancy. So when we say gestational diabetes, it is the diabetes which is diagnosed in the second or the third trimester of their pregnancy. So the clinical diagnosis is usually done in between 24 to 28 weeks of pregnancy, and that's when, if there is found to be hypoglycemia, then the patients are diagnosed to have gestational diabetes. And patients who are diagnosed in the first trimester of their pregnancy are termed as pre-gestational diabetes. That means they would have had the diabetes before the pregnancy itself, and at the time of screening, which is the universal screening followed here in India, so all the pregnant women, as soon as all the women who get the pregnancy positive are tested for their blood sugar levels, and if they are found to be uh, having high blood sugars in the first trimester, it is diagnosed as pre-gestational diabetes. Then there are other varieties of diabetes. It could be because of some drugs, so patients on treatment for some other conditions like asthma or COPD, and patients who are on steroids, and patients who are treatment for other immunosuppressive drugs, or on organ transplant drugs, or post-HIV, post-AIDS. And there are, of course, there are other monogenic forms of diabetes, like you have something called as MODY, that is the maturity onset diabetes in young, and cystic fibrosis related diabetes. So there are these are other forms of diabetes, and diabetes related to pancreatitis, which is again one of the common scenarios which we come across. So also this diabetes is termed as the diabetes because of pancreatitis is termed as type 3C diabetes. So we have type 1 diabetes, type 2 diabetes, gestational diabetes, and the other forms of diabetes related to some of the reasons which I just mentioned. So these are the varieties or the types of diabetes. Now, once we know the types of diabetes, now we will look at the criteria for diagnosing diabetes. So how do we diagnose? So what is the criteria to say somebody is diabetic? So as per the ADA standard, that is the American Diabetic Association standards, which all of us kind of follow universally, and even the RSSDI standards. So these guidelines say when you want to diagnose somebody with diabetes, so you're looking at the fasting, when you're doing a fasting blood sugar after the overnight fast of about 8 hours. So when you check the fasting blood sugar, which is more, if it is more than 126 milligrams per deciliter, it is termed as diabetes. Or if the postprandial, we kind of do a glucose tolerance test, that is the oral glucose OGTT, what we call oral glucose tolerance test with 75 grams of anhydrous glucose. So after this, if the post 2-hour blood sugar is more than 200 milligrams per deciliter, they're diagnosed to have diabetes. And of course, there's another parameter which I just told you, which is called as HbA1c, that is the glycated hemoglobin. So a glycated hemoglobin of more than 6.5% again is termed as diabetes. And or any random sugar more than 200 milligrams per deciliter with symptoms of diabetes, like increased thirst, urination, infection, weight loss. So all this, these are the criteria to say somebody is diagnosed with diabetes. So you have fasting blood sugar, you have OGTT, post OGTT more than 200, HbA1c of more than 6.5%, or a random sugar of more than 200. So these are some of the criteria to diagnose diabetes. And then of course there's something called as pre-diabetes, which we should know, and which is also very important. So as I told you, if you want to diagnose as pre-diabetes, then if the fasting blood sugar is between 100 to 125 milligrams, it is termed as pre-diabetic. And if the postprandial, that is post-OGTT, the blood sugar is between 140 to 199 milligrams per deciliter, it is termed as IGT, or even a pre-diabetic in the range. And if the HbA1c is between 5.7 to 6.4%, again they are diagnosed to have pre-diabetes. So these are some of the criteria to say somebody is pre-diabetic and somebody is actually diabetic. So pre-diabetic is why it is important, because here is one of the risk factors where you can actually reverse the diabetes. And also the cardiovascular risk complications, many studies have shown even in the pre-diabetic stage itself, there's an increased risk for cardiovascular, or the complications actually start setting in even at this stage itself. So that is why it's very important to try and diagnose or pick up pre-diabetes patients and try and help them to reverse or go back to a normal glycemic state. Now we look at the diagnosis for gestational diabetes. So gestational diabetes, as I told you, is diagnosed in the second or third trimester of the pregnancy, and it is done using a one-step or two-step method. So there are different methods. The common method which is followed is a oral glucose tolerance test again. So when you look at diagnosing a gestational diabetes, after an overnight fast of 8 hours, if you are doing an oral glucose tolerance test with 75 grams of anhydrous glucose, so you looking at a fasting blood sugar, which is if it is more than 92, and 1 hour post glucose consumption, 1 hour glucose of more than 180 milligrams per deciliter, and a 2 hour glucose more than 153 milligrams per deciliter. So 90, 92, 180 and 153 milligrams per deciliter. These are the parameters to have somebody to diagnose for gestational diabetes. Out of the three, if any one value is above the target which I just mentioned, they are taken as gestational, they are diagnosed as gestational diabetes, and obviously the treatment would be started for them. So that is about gestational diabetes and its diagnosis. So now we will actually look at the risk factors for these patients who are actually getting into diabetes. So why should somebody get into diabetes, and whom should we look at for screening and try and probably pick up patients early and also try and help them reverse their diabetes or even pre-diabetes to a normal glycemia. So there are different risk factors which are known kind of to evaluate and to pick up the patients early or even to diagnose the diabetes. So for all adults who are age of 45 years and above, the screening for diabetes is started. So that is the usual recommendation. 45 years and above, all adults should be screened for the presence of diabetes. So it can be in the form of an annual health check programs which the patients do undergo. Most of them do undergo, and that's how you try and identify if the patient is normal or diabetic. So age is one of the criteria. So if you're found to be normal, then obviously you start doing the or checks and probably every once in 3 years. But if found to be in the if you are found to be in the pre-diabetic, then you will obviously have to start doing the check more frequently, probably every year. So there are other reasons or other risk factors. So somebody BMI is a very important risk factor. Somebody is overweight, obese. For Asians and Indians, the BMI cutoff to call as overweight and obese starts from 23 kg per meter square. So somebody over 23 kg per meter square, you start screening them for the presence of diabetes. So irrespective of the age, if they are overweight or obese, so you can even start the screening at a much earlier stage. Then the other risk factors like presence of hypertension and presence of dyslipidemia, that is increased triglyceride and decreased LDL, HDL levels, and of course presence of weight, as I just told you, obesity is one of the risk factors, and you have other risk factors which can actually be looked for in women. Presence of polycystic ovary syndrome, again a risk factor to look for the presence of diabetes, and somebody who's had a history of previous cardiovascular disease or early cardiovascular disease or a family history of diabetes, a very important factor. Again, these are some of the patients who you can actually start screening for diabetes. So once you start screening, and if they are found to be normal, then every 3 years you do the screening, or if they are found to be in the diabetic range, then of course the treatment and the follow-up will start. If they're found to be in the pre-diabetic, then annually you start following them up to see that whether they are reversing back towards normal or progressing towards diabetes. And in women, somebody with a history of gestational diabetes, again important thing. So we do have patients with gestational diabetes, and somebody diagnosed with gestational diabetes. So the screening should happen once in 3 years after the delivery. So post-delivery, you check post-delivery the blood glucose level and found to be normal, then onwards you start screening every once in 3 years all through their life. So that's what the screening for gestational diabetes is recommended. So that's about the risk factors, the screening, so whom to look for diabetes and when to pick up diabetes based on the risk factors. And there's also something called as diabetes risk score. That happens to be a scoring based on the age, gender, body weight, previous history of gestational diabetes. So based on all these factors, if your scoring is more than 5, then you are at risk for getting into diabetes. So there is a diabetes risk calculator or the diabetes risk scoring, where you can try and actually identify um, patients who can get into diabetes risk population. So now we know the risk factors, where and how to pick up these people. So what are the preventive measures do we have? Usually it is understood or it is recommended that if you try and lose at least 7 to 10% of your body weight, you can actually reverse diabetes. So diabetes reversal is possible, and there are many studies like the diabetes preventive programs, the diabetes preventive studies which are actually done and shown that compared to diet and exercise and patients who are on medications, um, initially probably, so this diabetes prevention program was done to compare between diet, exercise and patients on metformin, which is one of the medications used for diabetes. And the reversal of this patients was possible, and it was much better for patients who were on diet and exercise. So nearly about 58% of patients who are found to could reverse their diabetes into normal glycemia over 3 years. So that is the actual kind of a good significant percentage of population which can actually reverse the diabetes, and it's very reassuring because diet and exercise plays a very important role in reversing somebody's diabetes or in the pre-diabetes stage to normal glycemia. And of course, as I already told you, a good weight reduction of nearly 7 to 10% of weight reduction can actually help in reversing the diabetes to normal. But of course, the diet and exercise or the lifestyle should not be left off after you get into normal glycemia. You should maintain a healthy lifestyle so that you again prevent from getting into pre-diabetes or getting into diabetes stage. So that is the importance of prevention of diabetes and also the reversal of diabetes. Again, as I told you, why it's important, because the pre-diabetes stage itself, patients are at risk for increasing their cardiovascular risk factors, and of course the other complications related to the cardiovascular diseases. So that is why it's important to try and reverse the patients if possible. And of course, this should be reassuring to the patient also if you try and tell them that it is possible, and it's just that the effort of the weight loss and the healthy lifestyle which has to be practiced. Now we look at the symptoms of diabetes. So we saw the risk factors and the preventive measures. Now let's look at the symptoms. What patients come with? So obviously these are commonly known symptoms. So patients can come with increased thirst, increased urination, infections, particularly urinary tract infection in men. It can happen in both men and women, and they can also come with blurring vision, extreme fatigueness, or they can come with more weight loss, and these are some of the increased hunger. So these are some of the symptoms where patients can present with some diabetes, and particularly in men, patients can also come with again balanitis and also they can come with loss of muscular mass or the muscle mass, and they can also come with decreased libido, erectile dysfunction. So these are some of the factors which is important whenever you're kind of talking to a patient and eliciting the history. These points should be looked after. In women also, they can come with vulvovaginitis and fungal infections. So again, you should probably suspect that these patients could be having diabetes and screen or look for diabetes in these sets of patients. So this is some of the symptoms of diabetes. Now we will go into the individual types of diabetes. That is, as I told you, there are a number of varieties of diabetes. That is type 1, type 2, and gestational diabetes, and so on. So we look at the different types of diabetes. So type 1 diabetes, as I told you, it amounts to about 5 to 10% of the population, and usually occurs in children or young adults less than 25 to 30 years of age. So having said that, that's not that, that is just a kind of a arbitrary age cutoff, and it's not that the type 1 diabetes should not happen at a later age. So it is seen, type 1 diabetes also seen in elderly population as late as even 60, even 80 years, the patients can present with type 1 diabetes. So they amount to about 5 to 10% of the total diabetes population. And there are, again, I told you the type 1 diabetes, the most common reason is autoimmune process. So autoimmune destruction of the pancreatic beta cells is the common cause. Of course, the triggering factor is not really known. Sometimes even infections can trigger this autoimmune process. And um, in this autoimmune process, body's own kind of antibodies, which I'm going to talk about, they are going to go and destroy or the pancreatic beta cells which produce insulin. They kind of destroy the pancreatic beta cells completely. So they're completely insulin deficient, and they're not left with any. They're completely insulinogenic, and there is no insulin. So uh, the only treatment for these patients would be just insulin, and no other oral medication will work in these set of patients. So there are about 5 types of antibodies which causes type 1 diabetes. So one is the insulin autoantibodies, then you have the ICA512 antibodies, then you have the GAD65, that is the glutamic acid decarboxylase antibodies, then you have the insulin autoantigens, then you have the zinc transporter 8, which is one of the fifth antibodies. So there are about 5 antibodies which can cause or lead to type 1 diabetes. And the other subsets of type 1 diabetes called as LADA, that is also called as type 1.5 diabetes, which can actually be sometimes confused for a type 2 diabetic, because these patients kind of respond to oral diabetic agents, oral medications initially, but very soon they are going to go on insulin, and they stop responding to oral diabetic agents. So you have type 1 diabetes, and of course the LADA, that is the latent autoimmune diabetes in adolescents. So again, one of the subset forms of type 1 diabetes, what we could say. So this is about type 1 diabetes and its causes. So patients with type 1 diabetes can commonly present with very high blood sugars there, because they're completely insulinogenic. So they can present with very high blood sugars, and quite commonly they can also present with something called as DKA, that is the diabetic ketoacidosis. So as the name suggests, diabetes ketoacidosis, it has 3 components. So very high blood sugar, diabetes, ketosis, that is increased levels of blood ketones in the body because of breakdown of the fat, and also there is metabolic acidosis. So patients can present with DKA or diabetic ketoacidosis, and which is kind of a life-threatening situation if not treated appropriately. And of course, the blood sugars and the ketosis and the acidosis, all of them has to be corrected. Otherwise, it can be a life-threatening situation. Patients with type 1 diabetes can also present with dehydration, extreme or the very high blood glucose, weight loss, infections, and these are some of the kind of symptoms where patients with type 1 diabetes can actually come into your clinic and probably present, and we should look at the phenotype of the child or the adult who is coming in, and also the blood sugars and the urine ketones and the blood ketones. These are some of the things where you try and pick up and diagnose them as type 1 diabetes, and of course the treatment should be started appropriately. Now let's look at the type 2 diabetes. So if you're looking at type 2 diabetes, again, as I told you, it forms the major component of diabetes. So it amounts to about 90 to 95% of the population with diabetes are type 2 diabetes. It usually happens, it can happen in the earlier days. It was said that type 2 diabetes usually happens in the elderly population, older population. But in the recent times, we are seeing patients who are young adults, middle-aged population, can also, who are particularly overweight or obese, can present with type 2 diabetes because there's an increase in insulin resistance, lifestyle, lack of physical activity, all of them form the risk factors. But so on, even in clinical practice, we see even children coming with presenting with type 2 diabetes, again, obese or overweight children can actually present with type 2 diabetes. So this is some of the reason the overweight or obesity is one of the major risk factors for somebody to get into diabetes, and particularly the type 2 diabetes. And of course, the lifestyle plays a very important factor, and lack of physical activity, exercise, do play a very important factor. And of course, there's a family or the genetic risk for type 2 diabetes again. So that amounts to about 30 to 40% genetic risk for someone to have type 2 diabetes. Then there are, of course, other risk factors which I mentioned at the beginning of the talk, how they can and why they can present with type 2 diabetes. And the symptoms would be more or less similar. They can present again with high blood sugars, and they can present with weight loss. They can present with osmotic symptoms, that is increased thirst, urination, infections, blurry vision, extreme fatigueness, increased hunger. These are some of the symptoms that patient can present with type 2 diabetes. And most often we also see in clinical practice that many patients who are diagnosed with type 2 diabetes may not have actual symptoms or may not have any symptom at all. They may just be picked up on routine screening, like they go for a medical check just as a routine check, and they are diagnosed to have type 2 diabetes. So it's again a very common scenario. And they are also otherwise diagnosed when they come to the hospital or go to a physician or a doctor for some other reasons, or they can come with to the hospital in form of any cardiac emergencies like a MI or a heart attack, or they can come with strokes, they can come with wounds or ulcers, and they can come with decreased renal parameters. So these are some of the other, other than who do not have actually any symptoms, and they're actually landed up in hospital emergencies for other reasons. And but they're when the blood sugars are checked, they can actually have type 2 diabetes. So these are some of the scenarios where patients can be diagnosed for type 2 diabetes, apart from the typical symptoms which we expect to see. And they can actually be diagnosed during the routine checks, as I told you, or in hospital emergencies, or even patients screen for other causes, and probably then you pick up a case for type 2 diabetes. So that's about type 2 diabetes, and briefly why it happens. So then we're looking at again the gestational diabetes. As I told you, it can happen diagnosed between the second and third trimester, between 24 and 28 weeks of pregnancy. So why it is important, or why it happens, basically, first of all, the gestational diabetes can happen because pregnancy itself, there is an increased insulin resistance normally. So because one of the factors is increased insulin resistance, which is compounded by some of the placental hormones. There's something called as human placental lactogen, or the human placental growth hormone, and there's also decreased adiponectin levels, and of course increased lipolysis and other factors which kind of increase inflammatory markers. We'll not go into the details of it, but of course these are some of the reasons why somebody can get a gestational diabetes. So that is why it's important. And why should we worry about gestational diabetes? Again, it can be detrimental both for the mother as well as for the baby. So that's why we should be worried about gestational diabetes. For the mother, there could be maternal complications such as preeclampsia, or hypertension, or there could be polyhydramnios, and there could also be increased or worsening of pre-existing, if they're pre-gestational diabetes, that is before pregnancy itself, there could be worsening of retinopathy, nephropathy, that is both eye and kidney issues can get aggravated because if the blood sugars are not controlled well. And then we for the fetus, of course, it could be in the form of basically macrosomia, what we call that, and that is baby born a big baby, or the increased body weight of the baby when it is born, and hyperbilirubinemia, that is prolonged jaundice to the baby, hypoglycemia to the baby after it is born, and there could also be cardiac malformations, most commonly the coarctation of the aorta, or with the ventricular septal defects, atrial septal defects, and these are some of the risk factors for the fetus. There could be also other risk factors like the central nervous system risk factor for the neonate once it is born. So they could have spinal defects, they could have gastrointestinal or the urinary tract defects. So these are some of the complications of high blood sugars in pregnancy. So basically, there's not much time in pregnancy, as we know. They are usually diagnosed, even if they're diagnosed in the first trimester, that's the pre-gestational diabetes. So they have only about 9 months to have a good glycemic control. Otherwise, they could have any of these complications. Likewise, if they're diagnosed in second and third trimester, again the time period is very less. So it's important to have a good glycemic control. I'll come to the targets of into each of this in a bit. So it's very important to have a good glycemic control in such a short period of time, particularly in pregnancy, because we do not have much of a time to prevent the complications. So it's a very short time, just about 6 to 9 months, depending on when they are diagnosed in pregnancy, and of course to have the sugars, which is the recommended targets are also very strict in pregnancy with diabetes. So that's why it's important to diagnose and treat women with diabetes in pregnancy. So that is about gestational diabetes. So now we will move on to the treatment of these individual types of diabetes. So before moving on to the treatment, we'll look at the targets for diabetes. What is the target which is set, and why is it important? So the targets for diabetes would be for the both type 1 and type 2 diabetes in general. I'm talking about the target for a fasting blood sugar ranges from 80 to 130 milligrams per deciliter. Again, these are as per the recommendations by the ADA and the EASD guidelines. So the 80 to 130 milligrams per deciliter for fasting blood sugar. For the postprandial, the target should be below 180 milligrams per deciliter, and the HbA1c, which is a 3 monthly average. Again, a very important test, HbA1c. Not many people do the test quite regularly, which is recommended to be done every 3 months. So, because if you don't do the HbA1c, neither the treating doctor nor you as a patient will come to know whether your diabetes is under control or not. So HbA1c is the test which is done to know your diabetes control, and also it helps in managing your diabetes better, and also to prevent the complications. So it gives HbA1c is an average of the 3 months of your blood sugar, that is 90 days of your blood sugar. So the recommended target for HbA1c is supposed to be less than 7%. So these are the cutoffs. So below 7% HbA1c, it is seen that you prevent most of the complications, or even delay the onset of these complications in diabetes. That is why these numbers are given. HbA1c of 7%, the fasting sugar 80 to 130, and the postprandial of less than 180 milligrams per deciliter. So this is for both type 1 and type 2 diabetes. Again, these targets are flexible, and they can be individualized based on a clinical scenario, based on your individual patient. So if as I told you, it can be even up to 7.5 or even 8%, depending if you have a very young child with type 1 diabetes, probably you can relax it to about 7.5 or 8%, and then as the child grows up, so you can tighten the targets to 7%. Likewise, even in elderly patients who are chronically ill, who are having probably some other comorbid conditions, whose survival is not expected to be long, even in these patients, the HbA1c target can be relaxed up to about 8 and 8.5%. But in general, just to remember, HbA1c target is about 7% and below to have a good glycemic control. So this is for type 1 and type 2 diabetes. So, and when you're looking at the different treatment options for type 1 diabetes or type 2 diabetes. So if you're looking at type 1 diabetes, obviously you're looking at the treatment would be, as they're completely insulin opinion, the treatment would be just only insulin and nothing else. So it will be either something called as a basal bolus insulin, that is 3 bolus insulin and 1 basal insulin, which is trying to mimic the normal physiology of insulin secretion. That the basal bolus regime is the most kind of a gold standard kind of a treatment for type 1 diabetes, or the insulin regime treatment. Or you could also use the insulin infusion pumps, which are quite often acceptable and pretty easy to use and also easy to manage your diabetes. That is the treatment for type 1 diabetes. If you're looking at treatment for type 2 diabetes, you have multiple options. You have oral diabetic agents. So again, in oral diabetic agents, there are a variety of drugs again which can be individualized depending on the clinical scenario and depending on your patient comorbid conditions. And you also have GLP-1 receptor agonist, or even you have insulin, which is the most potent among all. So you could use any of these agents depending on individual patients, and of course any permutation or combination can be used to get into the glycemic target of 7% and below. So these are the treatment options for type 1 and type 2 diabetes. Now we're looking at the gestational diabetes treatment. As I told you, the target for gestational diabetes is very tight. So here the fasting sugar target is supposed to be less than 95 milligrams per deciliter, and here and we check 1 hour post breakfast or after food blood sugar levels, and the target for either 1 hour after breakfast, 1 hour after lunch, or 1 hour after dinner, the target should be less than 140 milligrams per deciliter. So mind you, these targets are based on the glucometer readings for gestational diabetes. So we're not looking at the lab readings when we are monitoring. For gestational diabetes, we're looking at the glucometer readings, and the targets are less than 95 for fasting and less than 140 after 1 hour after each meal. So this is the target. And here in gestational diabetes, we are not worried much about the HbA1c, because the increased red cycle turnover happens, and HbA1c actually does not give actual or the correct control. So we are really not worried much when somebody is diagnosed with gestational diabetes. So here we are looking at the blood sugar readings as a target, and of course we try to keep in the target to have a safe and safe pregnancy and also a safe delivery. So that's the treatment option, or even the target for gestational diabetes. Now we look at the complications of diabetes. Of course, when you have diabetes, all of us know that diabetes can lead to many complications, and they can broadly be divided into acute or chronic complications of diabetes. So, if you're looking at the acute complications of diabetes, so they could the most common acute complication, as I already mentioned, is diabetic ketoacidosis. So that's commonly called as DKA. So there's diabetes, ketosis, and metabolic acidosis. All of them, it can usually present with type 1 diabetes, as I told you, and also somebody even in type 2 diabetes who are uncontrolled, or who are probably having some infection, or who are had a trauma or surgery. Even in these patients, you could have DKA with type 2 diabetes. So the treatment for DKA is very important, as I told you. Otherwise, there's one of the emergencies where you could lose your patient because it is life-threatening if not treated well. So the treatment would be, we'll not get into the details much, but the treatment would be correction of the hyperglycemia with insulin, correction of the dehydration with the IV fluids, and also correction of the ketosis and acidosis, again using both insulin and the IV fluids, and if required, maybe bicarbs can be used, but they are not really commonly used. So it's only used in if the cutoff of pH is less than 7%, if the acidosis is severe. But otherwise, just IV fluids, insulin would be good enough, and of course, and if required, any antibiotics can be used to correct the DKA. And of course, from IV insulin to subcutaneous insulin, they should be transited and then probably taken on from them. So that's about one acute complication of DKA, and the other acute complication is HHS, that is a hyperosmolar or hyperglycemic state. Again, one of the emergencies which can usually happen with type 2 diabetes, and usually in elderly population. Again, here they can kind of mimic DKA, but the only difference is they may not be, ketones may be very, may be absent, or even if they're present, they may be in milder forms or in lesser quantities. So ketones is not a very significant thing, and even the acidosis is not very significant. So they have they do not really have acidosis or ketones, and just the hypoglycemia, which can usually be beyond 500 or 600 and above, and of course they are dehydrated. So again, the treatment will be IV fluids and insulin, and of course correction of both the factors and getting the glycemia under control. The other acute complications, when you're looking at, of course, hyperglycemia, you're also looking at hypoglycemia. Hypoglycemia is also a very important factor. It can present as an acute emergency, as we know. So hypoglycemia can be due to drug-induced or insulin-induced, so whatever it could be, so or even missed meal. There are many reasons why somebody can get hypoglycemia. It can be due to infection. So there are a couple of reasons for them. I mean, to somebody to have hypoglycemia. Again, a very important factor, because hypoglycemia can actually be detrimental and also it can be life-threatening sometimes. So it can cause seizures, fractures, falls, fractures, accidents, comas, even hypoglycemia-related deaths are also reported. So a very important acute emergency in diabetes, and there are other infections which can present as acute emergencies. So you have something called as malignant otitis media, that's infection of the ear. You have emphysematous pyelonephritis, emphysematous cystitis. And then you have, of course, some of the other chronic infections like tuberculosis and so on. And again, a very important fungal infection which I just thought of mentioning is mucormycosis in diabetes. So again, can be life-threatening fungal infection in diabetes, particularly with type 1 diabetes. So if not treated well, probably you would lose the patient. That's about the acute complications. Now we look at the chronic complications of diabetes. So here you're looking at broadly again subdivided into microvascular and macrovascular complications of diabetes. So if you're looking at microvascular complications, it is retinopathy that is affecting the eye, and nephropathy affecting the kidneys, and the neuropathy affecting the nerves in the legs or the hands. And I'll come to each one of them. And you have the macrovascular complication, that is increased cardiovascular disease complications, or you also have strokes, or you also have peripheral vascular diseases. These are the macrovascular complications. So all of them can happen in a diabetes patient, or any one of them can happen. So that's why it's important. And one of the landmark studies, like we call UK-PDS study, it is shown that every 1% drop in HbA1c can actually significantly reduce both the microvascular particularly and also the macrovascular complications. So that is why again I told you HbA1c is a very important factor. So from a higher HbA1c, even 1% drop closer towards the HbA1c, target HbA1c of 7%, you reduce the complications, both micro and macrovascular complications, quite significantly. So the microvascular, as I told you, retinopathy is one of the nearly 40 to 50% of the patients can get affected with retinopathy in different forms. It can just be in form of microaneurysms, hard exudates, which all can lead to kind of decreased vision, impaired vision, or even sometimes leading retinal detachments happening, leading to complete blindness. So diabetes is one of the leading cause for blindness. Nearly about 30 to 50% can happen because of diabetes. So that is why it's important to have a good glycemic control. Then you have the nephropathy, again a very common cause. 20 to 30% of patients are prone to have nephropathy and decreased EGFR, that is decreased kidney functions, and they can also they can progress to end-stage renal disease or even dialysis. So most of the patients who come for dialysis are commonly diabetic or even hypertensive. And so diabetes can damage or fail the kidneys, and they may have to be on dialysis or even renal transplant after that. So again, a very important risk factor. Then you have the neuropathy, where diabetes can actually damage the peripheral nerves of the hands, or most commonly the legs, and which can lead to altered sensation, and they could have numbness, which can lead to lack of sensation, which can increase the risk of trauma, wounds, ulcers, which can go unnoticed. So these are the microvascular complications of diabetes. Then you have the macrovascular complications of diabetes, mainly the cardiovascular risk. So it's very important that the cardiovascular risk complications can actually worsen or increase the risk of death in a particular patient. So the cardiovascular risk factors like myocardial infarctions, unstable angina, so the chest pain, and heart attack, there's the infarction, and also most importantly, they can lead to heart failures, or even they can lead to sudden death. So now these are the cardiovascular complications, and it is understood that diabetes patients really have about 2 to 3 times higher risk for cardiovascular disease than normal population. So the cardiovascular disease is nearly 2 to 3 times higher than a general compared to general population. Then you also have increased risk factor of stroke events. So there could be strokes, and there could be paresis or paralysis because of diabetes. So uncontrolled diabetes can actually increase the risk for stroke in a particular patients, which we again quite commonly see in a clinical practice. And also the other macrovascular complication is peripheral vascular diseases, where there can be wound, non-healing wound, or ulcers, or even leading to amputations of the legs, which is quite common in diabetes patients. So all of this can try, and it can be avoided to a great extent if you have a good glycemic control and the recommended target for your glucose level, and most importantly, a regular follow-up with your treating doctor or treating physician or a diabetologist or endocrinologist, so that you try and prevent these complications as much possible. So that is why it's important for regular follow-up every 3 months or even every 6 months with your regular doctor whom you're consulting for your diabetes, so you prevent these complications. So these are broadly the micro and the macrovascular complications, that is among the chronic complications. You also have the autonomic neuropathy complications. Some of them can be cardiac related, like leading to increased heart rate, orthostatic hypotension. That's when the patient stands up, there could be a sudden drop in the blood pressure, and you could have the gastrointestinal autonomic neuropathy, where commonly it can have present as gastroparesis, alternating diarrhea, or even constipation. You have the genitourinary complication because of the autonomic neuropathy, leading to infections, cystitis, bladder infections, or even in men can also lead, it can lead to erectile dysfunction, retrograde ejaculation, and so many other problems because of this neuropathy, uh, autonomic neuropathy, because of diabetes and uncontrolled blood sugar levels. So that's about the chronic complications of diabetes. So when you know the complications, you actually have to screen for all these complications. So you're looking at a screening for complications, because only when you screen, you identify and you prevent the problems. So in terms of screening for type 1 diabetes, which can happen in children and young adults, as I told you, the screening for type 1 diabetes complications, which I just listed out, the screening should be started at 5 years after the diagnosis of diabetes, or if the patient is 10 years of age, or even they attain their puberty. So this is for type 1 diabetes, and of course you screen for the blood sugars, the HbA1c, and the renal parameters, most importantly, to see any decrease in the EGFR or reduced renal functions, and you screen for retinopathy changes, you screen for all these problems, so that you try and actually prevent, and you screen for urine microalbumin creatinine ratio to prevent any renal parameters or even any other risk factors associated with type 1 diabetes. So that's about the screening for type 1 diabetes. In briefly, when you screen for type 2 diabetes, so again you look at all these parameters as a screening, but in type 2 diabetes it is screened, or the screening is begun at the diagnosis itself. When somebody is diagnosed with type 2 diabetes, then itself you should screen for all this parameters, that is starting from the retina, eye screening, your sugars, your HbA1c, your lipid, and you look cardiac screening, your foot screening for any neuropathy, urine for microalbumin creatinine ratio for any nephropathy, and your of course ECG and treadmill and echo can also be done depending on the scenario. So these are some of the screening for type 2 diabetes, which is done at the diagnosis, and every 3 monthly, as I'm again repeating it, your fasting blood sugar, postprandial blood sugar, and your HbA1c should be done and should be kept within the target of 7% every 3 monthly. And then annually once you could screen all of this so that you don't miss out on any complications, and if anything is identified, you could try and probably prevent, uh, treat it and probably prevent from further progression. That's why screening is important, and also optimizing the medications based on all these risk factors, whether it could be oral diabetic agents, insulin, or blood pressure lowering agents, or lipid lowering drugs. So all these medications should be optimized and treated as a comprehensive diabetic management rather than just controlling or treating only for diabetes. So basically diabetes is a comprehensive management disease, which kind of also needs a multi-speciality referral. Sometimes you could actually be referring to a cardiologist or a nephrologist or even an eye specialist or even a dentist. So based on all these factors, it's a multi-speciality approach and multi-speciality care to prevent the complications and to address any problems if at all it arises, and the treatment should be given based on these individual problems. So that's about the complications of diabetes. And lastly, diabetes and COVID-19, because we are in this middle of this pandemic and which is going on. So diabetes patients are not really at increased risk for COVID-19 infection, but of course, if the blood sugars are high, more than 180, 200 milligrams, or if the HbA1c is over 7%, um, they could be at risk of the treatment difficulties for COVID-19 can happen. That means the response to the treatment can be much delayed because of the hyperglycemia, and even the recovery from the COVID-19 infections with patients with diabetes because of the lack of immune response or these problems, the recovery from COVID-19 itself can be delayed, and other complications of treatment can happen for somebody with diabetes who's got a COVID-19 infection. So in general, they are not, the risk factor remains same as the normal population, but the treatment factors do get affected for for patients with diabetes and COVID-19 infection. So I think that's about diabetes and its complications. I've tried and covered briefly each and uh, each component of it. So thank you very much for this opportunity, and I think we will take up the questions now, and we can discuss further. Thank you. Yeah, I think I see some questions over here by Oliver Peter. So, hi, doctor. What should my blood sugar be, and what is HbA1c? So, as I just mentioned in this talk, the blood sugar control for fasting is 80 to 130, postprandial less than 180 milligram per deciliter, and HbA1c, the recommended target is less than 7%, and you could have it even close to 6.5% and below if by not having any associated or by preventing hypoglycemia, then that's a very good target. So next question by Mr. Narendra Chaudhary. Does diabetes increase my cardiovascular risk? Yes, again, as I told you, diabetes definitely increases the cardiovascular risk by 2 to 4 times higher than the normal population. So diabetes generally is also called as cardiac equivalent disease. So you're at the same risk as somebody who's already had a cardiac event. So the risk is definitely higher than normal population. Nikita, Dilip, so the third question would be, can I conceive if I have diabetes? Yes, you could conceive if you have diabetes. And of course, the preconception blood sugar target should be an HbA1c of the less than, HbA1c target of 6% or even up to 6.5% is acceptable. So somebody with a pre-existing diabetes before conception plan to have a HbA1c of 6% or beyond, definitely be below 6.5% before you conceive. Again, next question by Pushpu Desai. Will I always need medications or insulin? So, as I told you, there's something called as diabetes reversal, which is proven, when patients are off their medications or even insulin. So, there is a good chance in at least about 50 to 60% chance is what I could say, where you can reverse your diabetes and stay off the medications. But having said that, you cannot stop your lifestyle, practicing a healthy eating habits or regular physical activity should be practiced. But of course, you can come off your medications, and that is possible. There is a question by Dr. Harpal Singh Malhotra. Is it possible to have no complications in diabetes? And what about reversal of diabetes? Yes, to say no complications of diabetes, yes, it could be possible if you try and have a good glycemic control. And there's something called as a legacy effect of diabetes. So, once in the beginning you start having a good diabetes control, beginning of your diabetes, from then on you have a good glycemic control, and probably after a few years, even if you have a diabetes which is slightly on the higher side and you come back to your normal recommended range, um, you could try and probably uh, have no complications of diabetes. That is possible, and we have seen that in clinical practice. So, which is quite kind of a possible situation to have no complications. It can be, you can prevent both the micro or the macrovascular complications. But the most important thing is to prevent or delay the complications. Again, a good glycemic control is very important. So that's what it matters, and also exercise and dietary habits plays also a very important factor, to not to have complications or even to delay the onset of complications. And reversal of diabetes, I think I just answered that. Of course, reversal of diabetes means you try to come off your medications, and all these diabetes preventive studies or preventive programs have shown up to 58% chance is there to reverse diabetes just with diet and exercise alone. So that is what is reversal of diabetes. So you can uh, kind of revert back to normal, and you can probably not be on medications, and just on lifestyle change, that is diet and exercise, which needs to be continued, and that is possible. Is the next question by Swati. Uh, how often should I be seeing a doctor to optimize my diabetes management? So it is quite important aspect of diabetes management is what I would say. So you should be seeing a doctor every 3 monthly. The recommended is every 3 months with your blood sugar, fasting and postprandial, and with your HbA1c. If not every 3 months, then definitely on every 6 months you should see a doctor. And because diabetes is a progressive condition, it's a chronic illness, it's just not one-time treatment. So to optimize your medications and to have a good glycemic control, every 3 months it is recommended you see your treating doctor and get your diabetes, to see that your diabetes is under control, and also to optimize your medication. And if there's any complication which crops up, it can be addressed at the earliest. The next question is by Vaishnavi. Will high cholesterol and high blood pressure affect if I have diabetes? Yes, if you have high cholesterol or high blood pressure, this can add on to the risk factors with diabetes. That is meaning it can add on to your cardiovascular risk factors or even stroke risk factors. So it's important that you not only control your diabetes, also you control your lipid parameters by using lipid lowering agents. You control your blood pressure by using antihypertensives, so that you kind of have a comprehensive care along with your diabetes management, and of course you prevent the complications of diabetes. The next question by Shraddha Shah. Am I at risk for contracting infections if you have diabetes? Yes, diabetes, if the blood sugars are not very well controlled, if there is hyperglycemia, that is, if the blood sugars are over 180, 200, and the HbA1c percent is over 7%, generally you could be at increased risk for contracting infections, and it could be commonly urinary tract infections or any infections causing from um, common flu, fever. There could be any viral or bacterial infections or fungal infections which you could be at high risk, and also the recovery rate can be delayed if you have uncontrolled blood sugar levels. So definitely infection risk is higher if the glycemia is not well under control. The next question would be, can my kidney get damaged if I have diabetes? So yes, diabetes can increase the risk for your renal damage or the kidney damage. So that is why it nearly amounts to about 30 to 50% of patients with diabetes can actually have renal problems or kidney problems. It can just range from microalbuminuria, what we call, that is increased in the albumin excretion in the urine, um, there's something called microalbuminuria, macroalbuminuria, or even end-stage renal disease. So there are different stages particularly, and of course there are different stages of kidney deterioration based on the EGFR. So patients with diabetes are at increased risk for kidney damage. So it all the more becomes important that we have a good diabetes control. The next question will be by Sucheta Chakravarti. Are there any long-term complications of diabetes? I mean, how can you avoid them? Of course, the long-term complications that you just mentioned, it could be, both micro and macrovascular, like the renal damage or the retinopathy, eye damage, cardiovascular risk. I mean, cardiac problems, which are the most common in diabetes, particularly, MIs and heart failures, and sudden deaths, stroke. So these are the long-term complications of diabetes, and the best way to avoid them again would be to have your diabetes under control, and have a periodic checkup with your doctor, and be regular with the medications prescribed, be it tablets, be it insulin, or any other treatment options. It's very important that you take these medications as prescribed regularly, and you don't miss out on this medication. And if there try and follow up with your treating doctor every 3 months or even 6 months, and of course by doing all these parameters, and also having a healthy lifestyle, a very important thing, with diet and regular physical activity, so you can try and actually prevent these complications. So the next question: are people with diabetes more prone to COVID? Simply in one word, no. They're as much at risk as the normal population. But the only thing is, somebody with diabetes gets COVID, the if their sugars are uncontrolled, HbA1c of over 7% again, the treatment can get difficult, and even the recovery rate can be difficult for these patients with hyperglycemia, because you're going to use steroids and other parameters for treatment of COVID, which can actually worsen your hyperglycemia, which we have seen in hospitals. Patients with diabetes can have very high blood sugars when the treatment for COVID-19 is started, because the use of steroids, and their blood sugars can go uncontrolled over 300, 400, and the recovery can get complicated because of this situation. Okay, the next I think question would be, so please say something about neuropathy. So neuropathy is a very kind of a under addressed situation, complication of diabetes, what I would want to say, because it's a very difficult thing to treat neuropathy, because the symptoms, you're not going to actually the symptoms are very subjective. So the treatment for neuropathy is also not very satisfying in diabetes patients. But because of this neuropathy, there could be an increased risk for traumas, or even leading to ulcers, non-healing ulcers, wounds, because patient may not appreciate the pain because of a trauma or a wound, which can go unnoticed, and which can actually lead to kind of non-healing ulcers progressing to gangrene, or even which can lead to amputations. So neuropathy is a very difficult task, I would say, in treatment for diabetes. But of course, if addressed properly, you can probably try and prevent much of the complications, and you have appropriate footwear to treat neuropathy, appropriate testing, and the medications are also available to kind of decrease the neuropathic symptoms or the pain associated with neuropathy. The next question is, how many organs mainly get affected due to diabetes? Well, diabetes can affect almost all the organs in your body, is what I would say, starting from your eye to your kidneys to your heart to your liver. Um, I mean, it can affect almost any organ in the body. So, but that is why we say micro and macrovascular problems or complications of diabetes. There's literally no organ which is kind of spared because of diabetes. So, and that much is the risk for diabetes complications and its damage which can do. Also, I would say whatever damage done in diabetes most often becomes an irreparable or irreversible damage. So, diabetes, most of the damage, if it happens, it can be irreversible and leading to a permanent damage and a permanent disability. So the next question is by Mega again, how to prevent gestational diabetes. So see, the gestational diabetes, if you have a family history of, or if you had yourself had a history of polycystic ovaries, probably you could have a risk of gestational diabetes. If your family is a history of diabetes, then of course there could be some amount of increased risk for gestational diabetes. So again, gestational diabetes mainly happens because of the pregnancy itself and the placental hormones. So there are some placental hormones like the placental growth hormone or placental lactogen. So these are some of the placental hormones which can lead to increased insulin resistance and leading on to gestational diabetes. So there is nothing much you could do about it if it happens to you, but even then, you can try and prevent probably by again eating healthy, trying, and because in pregnancy women try to eat a lot of sometimes unhealthy food, I would say, a lot of sugars or sweets or chocolates and all these things are kind of because of pregnancy, even at home they could kind of give you a lot of high carbohydrate diet intake. So you should try and avoid this even in pregnancy, is what I would say. And also if some amount of exercise which is allowed in your pregnancy, usually simple walks or stretching exercises after each meal can try and prevent you getting into gestational diabetes, and also obviously having a safer pregnancy uh, with a normal, without gestational diabetes. So I think that's the end of all the questions. So thank you all very much, and thank you for those wonderful questions. I hope I've tried and addressed about diabetes in general and its also complications broadly, how it can kind of affect most of the organs and how it can cause the damage. There's one other question by Mr. Sandeep. In the pandemic time, how to reduce sugar levels and what are the precautions to be taken? So in the pandemic time, again, to reduce sugars, if you are diabetic, take the, try to have a healthy lifestyle, try to exercise regularly. Even if you're not able to go out, try to exercise indoors. Probably you could do indoor exercises. You could practice yoga or even stretching exercises, body weight exercises. So these are some of the exercises you could do, and also try and eat healthy because you are sitting at home in the pandemic. You should not really be binging on unhealthy foods. So diet and exercise, you should be cautious of what you're eating and how much you're exercising every day. So the recommended exercise in general is about 150 minutes per week of exercise. Moderate intensity exercises like brisk walk, treadmill, jog, or even small resistance training exercises add on, as an add-on to this. Probably weekly 2 or 3 times you could lift light weights at home. So these are some of the exercises you could follow, and also have a low carb diet intake, because we Indians try to take a high carbs in majorly in all our meals. So try to have a low carb and little high protein based diet, and eat small frequent eating is what we normally advise for our patients. So try and practice that, and try to eat at least 5 to 6 times, but in smaller portions and fixed time, with more of protein based diet, and reduce your carb intake. And of course, after diet and exercise comes your medications. So I always stress diet and exercise as the first part of your treatment, and then the medications do come. So the prescribed medications, it can be oral diabetic agents, the tablets, or the insulin, or even the GLP-1 receptor agonists. So whatever the treatment could be, please take the medications regularly. Do not miss them, and also do not miss your follow-up with your doctor. As I again tell you, every 3 months you should visit your doctor, or even earlier than that if it is asked for, and see that you have a good glycemic control. I would say again, stress upon the HbA1c test, because most of the treating doctors may not do the HbA1c test sometimes, and they may miss out on that. So just by checking the blood sugars, you will not know how the diabetes is. So blood sugars do fluctuate. Even every day it fluctuates, so you're not really knowing. Sometimes it can come normal, sometimes it can come high or even low. So that is why the HbA1c test is done, which is an average for 3 months of your diabetes control. And of course, as I told you, if you keep it below 7%, you will definitely try and avoid the complications of diabetes. And particularly in the pandemic situation, you can try and avoid the complications related to even COVID-19 by having a good glycemic control. So I think that would be end of all the questions. So thank you all, and thank you all for hearing me out. And I hope I was helpful in addressing some of your questions and relating to diabetes and its complications. So again, stay safe and stay healthy. And thank you all for this, um, for attending this talk and listening to me. Thank you.